Îl invit pe Basil să prezinte și să puncteze din punct de vedere al providerului de cfDNA care sunt calitățile și implicațiile și ultimele două statistici. Thank you. Please.
Hello everybody, my name is Basil Ayish and I am employed by Ayish Diagnostics, which invented the Harmony non-invasive prenatal cell-free DNA screening, to be precise. We have a CLIA certified laboratory in San Jose, California, where whole blood is tested from women of all ages worldwide who have singleton or twin pregnancies, from IVF or spontaneous conception, and whose fetus gestational age is as early as 10 weeks. Results are provided in as little as 3 days. With the dramatic changes in prenatal testing that have occurred in just the past few years, you have new options for delivering improved care to your patients. 4 years ago, there was only one cell-free DNA laboratory. Shortly after that, there were 3. Then there were 6. Tomorrow there might be 15. How do you decide among these options? I'll discuss tools for you to think about when evaluating options so that you can choose the right test for your patient and for your clinic. I'd like to first get a show of hands. How many of you have been able to provide some sort of cell-free DNA test to your patients? How many of you are doing it now? And how many of you think there is little to no differentiation from one cell-free DNA test to the other? This should be easy then. Okay, these numbers are not going to be strange to you. The conventional screening leaves a bit to be desired, especially in the false positive rate. That's always been a source of trying to improve the false positive rate. With Harmony now, you can have a 50-fold improvement over conventional screening. And what does that mean in real life and in typical practice? If you have 20 patients, one of those 20 will receive a positive result. But the reality is that most of those will actually be false positive. And what that causes is a series of events, referrals to specialists, additional testing, and waiting, and most importantly, perhaps, is very prolonged uncertainty for the patient, combined with safety concerns about the diagnostic test. Out of those same 20, 19 of them will receive a negative result. But we know with the detection rate of 85 to 90%, there is going to be some of those patients who will actually be, who would actually be positive for trisomy. So now comes along cell-free DNA screening. How do you differentiate one from the other? What kind of criteria do you base your decisions on? Some of the questions for you to think about are, is the test that you're considering validated in multiple blinded validation studies? Does the test you're thinking about measure, incorporate, and report fetal cell-free DNA? Not all tests do. How accurate is the result? Is it proven in all ages and risk groups? And how easy is it for you to get results? Let's take a look at the evidence part. When you take a look at the evidence of blinded validation studies, you want to make sure that there is reproducibility, meaning multiple tests, multiple studies, so that you have confirmation that the performance that's been presented to you as a marketing claim is most likely to be supported by the evidence. And the diversity of the population. How big was the population that was tested in those validation studies? Harmony has up to 17 times more patients that have been included in validation studies than other tests, and up to 5 times more studies that have been performed compared to other tests. If a test that is being presented to you is not on this list, it's because they don't have blinded validation studies of any kind. Are all studies equal? Blinded studies, of course, are at the top of the list. Blinded studies with outcome data is the top of the list. With outcome data, you can actually have confidence that the detection rate is going to be confirmed with the outcome. If you don't have the outcome data, all you can really count on is specificity. Registry studies, on the other hand, are very commonly used. They are in-house data based on commercial experience. They are not going to be accurate for outcome data. In most cases, they don't have much outcome data, and it's difficult to extrapolate from the limited outcome data. And what ends up happening is that you may overestimate the performance, or the marketers may overestimate the performance of the test that they're presenting to you. What about fetal cell-free DNA, the fetal fraction? Not all tests are actually giving any consideration to the fetal cell-free DNA. Not all tests measure, report, and include that amount in the risk score for the patient. We know that cell-free DNA varies from patient to patient and pregnancy to pregnancy. There are several variables that we know impact it, one of which is body mass. Another is gestational age. Since this is meant to be a screen at the early stage of pregnancy, in order to help manage the pregnancy, you want to be able to be sure that a test is actually measuring the fetal cell-free DNA, measuring it accurately, reporting it so you can actually see how much fetal DNA is there, and including that amount in the algorithm to determine the unique risk score for that patient. Tests that don't do that I'll show you what they're using to make their calculation. Because if there is very little to no fetal cell-free DNA, the test is going to be basing its result on the maternal DNA, and that causes male fetuses to be miscategorized as female. Those tests will generate a result when there is very low fetal cell-free DNA, and this gives patients and you as clinicians, as providers, a false sense of confidence that since the result was issued, it is a DNA test, there must be some accuracy to it, when in fact, there may not be any accuracy to it at all. Here's an example of two patients who were tested. They were sent to 5 different laboratories. Harmony gave back a no report for both patients because there was not enough cell-free DNA to be included in the algorithm. If we don't detect 4%, we don't report any amount of fetal cell-free DNA because detection below 4% is very difficult to be accurate. Panorama does report and measure fetal cell-free DNA. They also did not report a result because of low fetal fraction, but they did claim to identify 0.6% of fetal cell-free DNA. Maternity 21, by sequenome, identified the patients as both having healthy female fetuses and a fairly substantial amount of fetal cell-free DNA. They don't report that normally, but on follow-up questioning by the providers, they reported 4.3 and 3.9% fetal DNA. Illumina's test does not consider fetal DNA as part of the algorithm. They don't measure fetal cell-free DNA. They gave a clear bill of health for both patients, healthy female fetus. Neither of these patients were pregnant. This shows that not all tests are able to actually measure fetal cell-free DNA accurately, and it shows that those that do not measure fetal cell-free DNA will give you a result, but that result is based on something other than the fetus. How does Harmony differ? How does Harmony make the differentiation? First, we start with using SNP analysis to identify the fetal DNA from the maternal. We calculate that quantity, and then we also do the chromosome counts in a focused assay that looks at only those chromosomes we're interested in. 21, 18, 13, X and Y. We take that information, we include it into a bioinformatic algorithm that includes the chromosome counts, the fetal cell-free DNA amount for that woman, what her maternal age is and what is the gestational age to create a unique risk score only for her. The way that we start is we all start with the same genome. Massively parallel shotgun sequencing is the methodology that most other assays use. And when they do their analysis, they do counting of the whole genome. But chromosomes 21, 18, and 13 represent only 10% of the genome. So they're doing a lot of counting of the genome that is not relevant and not usable. Harmony takes a look at only those chromosomes we're interested in. It's a directed analysis, and we only look at the part of the genome that we want to get results on. And what happens to the test results? The results themselves will give you a very good separation for harmony of about 99% on either extreme, and the amount of fetal cell-free DNA will be clearly marked on the test report. This way, you have a good, easy indication on how to counsel your patient, how to show the patient what the result is, and you have confidence that the fetal cell-free DNA amount was measured accurately, and was sufficient for you to have confidence in the assay's result. This is in line with what the ACOG bulletin guidelines suggest, which is to give a risk score rather than using an arbitrary cutoff to say the screen is positive or negative. What about accuracy? If a test comes your way, if somebody comes to present a test to you, how can you measure the accuracy? How can you be confident about the accuracy? You go back to the data, you go back to the evidence, and you take a look at what is the combined accuracy of the trisomy 21, 18, 13 that is going to be tested in one panel. The assay will be as good as the weakest chromosome sensitivity. For harmony, the detection rate is 99% overall, and the false positive rate is 0.1%. Other tests have a fairly similar specificity, but the false positive rate differs from 0.2 to 1.4%, and that small difference between 0.1 and 0.2% will have a very significant impact on your confidence that the test result will be matched with the confirmatory testing, the positive predictive value. Positive predictive value, the number of true positives divided by true positives and false positives. The test with the lowest false positive rate will always have the highest positive predictive value no matter which population you are plugging these numbers in for. If we take a look at a population, 35-year-old population incidence of 1 in 250, this amount of false positive rate for the next best test of 0.2% versus 0.1%, on the face of it doesn't seem like a big difference. But in the positive predictive value, it's a 26% difference. So having the lowest false positive rate, even a 0.1% difference, has a very significant impact on the positive predictive value. And now for some information about all age groups. As has been discussed before, the 35-year-old cutoff is actually an arbitrary cutoff. It was based on economic considerations per what Professor Kipros talked about. And in this study, it clearly shows 87% of all live births are to women under 35, and of those women, 55% of suspected Down syndrome births occurred. So if the majority of Down syndrome births are to women under 35, shouldn't they be screened routinely? One of the problems has been that the cell-free DNA tests, when they were introduced, were looking at the over 35 crowd because that was the standard. When Ariosa developed Harmony back in 2000 and released it back in 2012, one of the very first things that we did was engage in a study of average risk, head-to-head against first trimester screening, which is the gold standard of screening. The objective was to make a test make a comparison that would stand up against any challenge. It was intended to be the largest blinded prospective study, 35 clinical sites in 6 countries, and complete follow-up of nearly 16,000 women. This study was published in the New England Journal of Medicine in April. The goal was to have it statistically powered for sensitivity and specificity for trisomy 21. In order to do that, we needed to have the outcome data. It's the first time a study of this size with this depth of evidence has ever been done. So here's the way it was structured. Enroll any woman, collect the outcome data on all of them, figure out what the statistical requirement is for it to be powered for sensitivity and specificity, determine that almost 19,000 women needed to be enrolled, and then go through and keep it blinded so that neither the patients, the clinicians, the providers, nor the researchers, the investigators, knew what the results were. Here's the guideline for first trimester screening versus non-invasive prenatal testing, the Harmony cfDNA. The patients were tested simultaneously, not sequentially. There was an earlier study done of average risk. They were tested sequentially, which meant that the cell-free DNA test was administered in the 2nd trimester. So fetal fraction is increased at that point. As a screen early in the pregnancy, this needed to be demonstrated at the same time the first trimester screen was being used. So Harmony was tested on these patients at the same time the biochemical markers were, and the ultrasound, 10 to 14 weeks gestation. Then the patients were followed all the way through. Outcomes were measured and recorded based on genetic testing or investigation, physical exam of the newborn. There were limitations. This test study was not meant to determine the sensitivity and specificity of trisomy 18 or 13. However, the data was collected in order to make it powered so that you could have reliance on the outcome data of the conclusion of the results. We would have needed to expand the number of patients enrolled because the incidence of 18 and 13 are much lower. Nevertheless, we do have data that suggests that Harmony in this study for 18 and 13 have a much better performance than first trimester screening. Another limitation is that first trimester screening is just one form of screening that's available to you. There's also the combined test, and combined testing may have a better detection rate than first trimester screening. That was not included in this study. So we start with nearly 19,000 patients. Each one gets Harmony, each one gets first trimester screening. Nobody knows the result of the Harmony. The clinician, the provider, is basing their health care on the first trimester screen results. Some of the women dropped out. 1.9% of them dropped out because there was no first trimester screen result. Another 3% dropped out because there was no cell-free DNA result. In the end, we have a sample size of 15,000, nearly 16,000 women, an amazing number. And here are some of the characteristics. The women's age, 18 to 48, 10 to 14 weeks gestation, 32 kilograms to 172 kilograms, and 3% of the women were IVF. So here's a schematic of the results. What you'll notice is that the chart here of the first trimester screen is extremely busy, all over the place. Those same 15, 16,000 patients are appearing here in the Harmony test. You have a dramatic separation of the high risk and the low risk, and a dramatic reduction in all of the noise of false positives that will allow you to have confidence in the performance of the results. Here are the numbers. The sensitivity, first trimester screen in these nearly 16,000 patients with outcome data, 21% of the true positives were missed. 5.4% false positive rate. That's not surprising. That's consistent with other studies on first trimester screening. 854 women had to have invasive testing unnecessarily. 9 for Harmony. Positive predictive value, you have a 20-fold improvement in positive predictive value. Combine the 20-fold improvement in positive predictive value with a 90-fold improvement in the false positive rate. These are numbers that are difficult to argue with. Well, I want to show you something. The overall trisomy 21 frequency that we found in this patient population is 1 in 417. This is an important number. It matches very closely the 1 in 413 that was demonstrated in the FASTER study. Other data points suggest that it's something like 1 on 700, but that number is actually based on births, not on pregnancies. How did we do on trisomy 18 and 13 compared to first trimester screening? Again, a detection rate of 8 out of 10, 9 out of 10 for Harmony, and the false positive rate for first trimester screening 0.3%. Again, 49 women having to have additional testing, invasive testing for confirmation, versus 1 for Harmony. That was for trisomy 18. Trisomy 13, there were only 2 real positives. And that's why, again, this was not done in order to, it wasn't powered for trisomy 18 and 13. You can imagine the number of patients we would have had to enroll to have it powered for these 2 chromosomes. So we have 1 out of 2 detected with first trimester screen, 0.25% false positive rate versus a 0.02% false positive rate for Harmony. Again, a 12% improvement, a 12-fold improvement in false positive rate. And what about the population? Was it skewed one way or the other? Was it really representative of the low-risk population? Almost 2/3 of the women who were screened fall in what is otherwise considered low risk. And the results are consistent with this population as it is with the whole study overall. 0.05% false positive rate, comparable to the 0.06% for the whole population of nearly 16,000. How would that look in Romania? If we took 100,000 pregnancies, roughly 50% of the number of pregnancies that happen in Romania, and applied these numbers, we would start with first trimester screening missing 50 of the real trisomy 21s, and 5,400 women moving forward to invasive testing unnecessarily, versus 60 if they were screened by Harmony. So the results, I think, are starting to make sense in terms of public health, that this kind of study can support the idea that, at least clinically, Harmony makes sense as a screen for all women. So we demonstrated that Harmony is superior to first trimester screening for trisomy 21. The 90-fold improvement in false positive rate and 20-fold improvement in positive predictive value. That shows that for a general population, Harmony is validated and the evidence supports it. Not all other cell-free DNA tests have this kind of evidence. Not all cell-free DNA tests are also validated for twins. Harmony, in fact, is the only cell-free DNA screen to accurately measure the fetal fraction contribution from each twin. We end up giving a result on the whole pregnancy. We measure each twin, we determine which has the lowest fetal fraction, and from that we are basing the health of the pregnancy in the bioinformatics. Harmony is validated for IVF, for egg donor, and surrogate pregnancies. How easy? Oh, this is additional evidence for the testing. There's a lot of talk about expanding the concept of cell-free DNA to include other things, expanding the panel. And we know the performance for trisomy 21, 18, and 13 is very good. As you add additional things, as you are looking for more things, the performance of the test decreases, the false positive rate increases. This is an elegant test for trisomy. It is less elegant for everything else under today's technology. Maybe in the future things will change, but according to today's technology and the evidence, this is a very good test, the best test for trisomy. Part of the reason is that the detection rate for microdeletion panels, for example, is as low as 60%. These are based on synthetic samples, not real life samples, and with an incidence of 1 to 5,000, 1 to 10,000, imagine the number of patients you would have to go through to find enough true positives to justify a claim of sensitivity. And then how easy is it? It's a simple blood draw. We work with several partners here in Romania. They can pick up the blood sample from you, send it to us. Once we receive it, as little as 3 days, we can generate the results. So Harmony is performed as early as 10 weeks. You get the results as quickly as 3 days. It's been studied in more patients than all of the other cell-free DNA tests combined. We're talking blinded studies, not registry. The accuracy has been demonstrated through those studies, and Harmony is the most widely used in 100 countries, more than 400,000 tests. So these are the things that I hope you will consider when you are confronted with new options for cell-free DNA testing, and your conclusion, I think, will take you to the right decision. Thank you.
Thank you. You didn't mention the no result rate.
The no result rate. Well, I mentioned the no result rate in the next study for Harmony was 3%.
From Romania?
I don't know the no result, but you would expect if the general population no result rate was 3% for Harmony to 1.9% for first trimester screening. That is the same, probably a similar kind of performance you could expect in Romania.
Thank you. Questions?